Our laws as it pertains to substances are draconian and bizarre. The psychopaths start this way. He was an alcoholic because of social media and pornography, PTSD, love addiction, fentanyl and heroin. Ridiculous. I'm a doctor, for sake. Where the hell do you think I learned that? I'm just saying. You go to treatment before you kill people. I am a clinician. I observe things about these chemicals. Let's just deal with what's real. We used to get these calls on Loveline all the time. Educate adolescents and to prevent and to treat. If you have trouble you can't stop and you want help stop it, I can help. I got a lot to say. I got a lot more to say.
Hello, everyone. Here we are. We're going to have calls today at 984-23... Oh, is that us? 984-237-3739? Is that correct? Excellent. We'll take your calls there. 984-2 Dr. Drew. And I see you on the restream. I see everybody there, and I'm watching you guys. Jay, I'm not sure I have a time for a Would You Rather right now. I've got a bunch of calls lined up. I want to get to them. We're going to have Dr. Samadi in here in about a half an hour. He, of course, is the urologist that brought us the Da Vinci robot that we use. He brought it to this country that we use for the radical robotic prostatectomy that is really standard of care for prostate surgery. And he has written a new book. New book's called The Ultimate Manual. I think I wrote a testimonial for that book too, because I thought it was quite
on the cover.
Yeah, I thought it was quite good. Where? I don't see it on the cover there.
It's in the red circle.
Oh, okay, there. And a good guy, a smart guy, and he was another one of the casualties of the panic porn and the cancel culture, and he'll tell you his story again about that. But in the meantime, let me get into some questions with you guys. Let's get right to it. This is Alex. What's going on, Alex? The phone's up, everybody. Alex is on the line. Hold on one second, Alex. We'll hear you in a second. We're just getting through some technical stuff here. Speak up.
Okay.
There you are. Thank you, sir. What's up?
Dr. Drew?
Yep.
I have a question regarding, I guess I could say, my sexuality since I've been abstaining from heroin.
Yep. Go ahead.
In this meantime, I've quit Cymbalta and heroin at the same time, and I have been a little bit quick on the draw, if we should say.
Oh, good. Well, sorry, but
Down
that's
below.
good. So here's a couple things. That's the least problematic side effect that you could have. Trust me, you can get all kinds of other stuff that goes on. The Cymbalta.
Very good.
Did you taper? You said Cymbalta? Is that what you were on?
Yeah, I was on Cymbalta 300 milligrams a day, 90 milligrams a day, and all of a sudden it was cut off, so I tapered down to 0 instantaneously.
Wow, that's a little rough. Did you have any withdrawal from that?
Yeah, I really did, and I was surprised to find, I Googled a few of the symptoms, but what we call the brain zaps, and
Yes.
a few of the kind of just bizarre, almost dizzy sensations
Yes.
compiled with my emotions have been, to be honest, quite all over the place.
Well, that's more likely the heroin, but let me just say that what you're describing is for people that don't know what this is. So the SSRIs particularly, it's usually Celexa, Effexor, sometimes Cymbalta, can cause this withdrawal syndrome. It's not a withdrawal syndrome like an opiate, we'll talk about in a second, but it's an unpleasant residual state that can go on for months of feeling electricity up your neck, zaps in the front of your head, buzzing, kind of a weird dizzy feeling. It's something about the state of, the chemistry that's left behind after these drugs. It does go back to normal almost always. I mean, literally almost always. So you can look forward to it getting better. The more serious issue is your heroin. And God bless you for stopping that. And that's a rough withdrawal.
Yeah, I kind of stopped them both in one fell swoop. I mean, if I'm going to get off one, let's get off the other.
Well, man, one. I'm not sure they stay in the same category, but okay. But
I wasn't prescribed. The heroin.
What? You weren't? I'm shocked to hear that. It's so surprising. But
I begged and begged the doctor for a connection that was stable, but unfortunately,
staying off the heroin is the hard part. So getting off is rough. And by the way, so now you say you have premature ejaculation. What can happen later is you can have delayed ejaculation and no satisfaction with ejaculation. So that starts to happen. That can happen at any stage along the way here, or not at all. So let's hope for you that it doesn't happen. And you should, if you're left just with the premature issue, count your blessings. That really literally is the least of the kinds of problems you can get into. And you can kind of.
So this could come from premature to almost non-existent.
Yeah, it can. But staying off the heroin, what are we doing about that? How are you staying off?
I've been going to meetings, and honestly, just the power of my own free will is just trying to abstain.
You must have done this before.
Yeah, I have. And this is my most recent relapse. It was kind of out of the blue. I didn't expect it.
Yeah.
Came through some problems with my divorce.
Yeah.
Blinked my eyes. Next thing you know, running with the wrong crowd. Here we are. And
okay, so
I wanted to say that.
What? Say that.
Oh, just this painkiller problem we have in this country.
Oh, my God.
This is what starts all of this problems on my end of the street.
Yeah.
Everyone I've talked to, myself included, we all started with Vicodin from a natural source and then graduated to blah, 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 and then here we are.
Did somebody give you an opiate this time, or you went straight to heroin?
No, I started with Vicodin, and I did the classic kind of stair-step my way through all the pain pills and meet people, and it's just the ladder, Drew, that we all go through.
No, I know, but
out
here,
there, I guarantee.
I understand, but I wanted you. So you're a heroin addict, and a doctor gave you Vicodin. Is that right?
Yeah, that's correct.
So you understand how insane that is. At the time, I'm sure you thought that was the best doctor ever. You understand now how insane this is. Please call that physician and direct him or her to learn from their behavior that this nearly killed you.
Yeah. Giving out the Vicodin was the hardest that I could do, and that led to this entire downfall.
Yep.
One thing leads to another that leads to harder, and it's like I'm asking my doctor for more refills. Of course they're going to give me more refills. Here you go. We got you. Everything's fine. Unbeknownst to me, taking the pills is basically the same thing as being an addict on the street.
Yeah, well, listen. Thankfully,
kind of sad. You don't really notice that until all of a sudden the pills are gone.
I know. Well, so they screw it up on both ends. They prescribe to an addict, which is insane, number one, and then when it's clear that you're having a problem, they cut you off, as opposed to call you in and say, "Hey, man, we got to get some treatment for this. I didn't realize this would happen. Sorry, let's get care." They just go, "You're a bad patient. Get out of here."
Yeah, pretty much.
Yeah.
Kind of made me feel just
so here's another thing I want. Yeah.
You're in here searching for pills. You're in here trying to get a doctor to write you another prescription. It's like, I'm just trying to get my leg to feel better, but
no.
Okay.
No. Hey, everybody, I'm a heroin addict. But here's the deal. Next time, if you have pain, Suboxone can be used for pain in opiate addiction pretty effectively. So that's something to think about, number one. And number two...
Well, Drew, and I'm going to ask you this, though. On my own, I mean, I set myself down, graduating down from my smaller and smaller doses of heroin. What do you think about Kratom?
Dude, you're still looking for opiates. You're looking for any way to get an opiate. You can't make that deal with God. So is that
though like switching Kratom for another opiate? Is it just switching? Because you think Kratom's a leaf from Southeast Asia. Maybe I can take a leaf.
You can also lick the mushroom Amanita phalloides and be dead in 12 minutes. So don't talk about the natural thing, number one. Number two, Kratom is, of course, better than...
Amanita muscaria?
Kratom, of course, is... Dude, you got to get back in the program. Your addiction is way active. You got to get back in. And this could have prevented...
That's what I'm worried about.
And if you've been in the program...
The fact that I've substituted something for a natural relief versus heroin.
Look, of course I'd rather see you on Kratom, but you'll just be on the road back to heroin. The deal is you got to get back in the program. Had you been in the program, you wouldn't have gone in the direction you went. Somebody would have pulled you aside and said, dude...
But Drew...
Yeah.
Here's my question. When I first got clean, I did the methadone program to a T for a year and a half and stepped down. And it did keep me clean for a year. But the methadone it felt like basically a substitute for what I was taking.
It is a substitute. I'm not telling you to do a substitute. I'm telling you to get a sponsor, go to meetings, and get your head right. Your disease is very, very, very active right now. I feel like, if we were in treatment, and this is not an unfamiliar experience for me, I would feel like I'm battling your disease, like we're just fighting it. And you got to run up the flag, you got to run up the white flag, and start going to meetings and get a sponsor, and take the feedback from people. And trust me, it's not going to be it's going to be straightforward. People are going to tell you what's up, and you don't know it. You're in it. It's not your fault. You're in it. Okay, let me get some calls going here. Okay. Kira, we're going to talk about post-traumatic stress disorder. Kira, is that right?
Yeah, it's Kira.
Hi, Kira. What's going on?
Yeah, I know I've struggled with a lot of things, depression and whatnot, and all stuff. And I actually been in therapy for a very long time, and my therapist actually diagnosed me as bipolar. But then later on, they undiagnosed me because I felt like I wasn't. They didn't think I was it. But anyway, I started reading about CPTSD because I actually was sexually abused from the time I was 4 to 14. And, I wanted to see, seek other treatments or other routes of just trying to get more information.
All right. So,
because I work in the medical field. So I always do. And I just wanted to know what you think about that. Cause I feel like that's what I have.
Yeah, you do. Slow down. Slow down. So a couple things. Yes. All that, all the anxiety you're having is part of that post-traumatic stress disorder, right? And so, there's two things I think you ought to focus on, okay, at the beginning of treatment for what you have. One, you probably need some cognitive behavioral therapy so you can get some improvement right now. Number one. Number two, you need to go get what's called EMDR, eye movement desensitization.
Right,
Okay. So and probably by two different therapists, I suspect, because it's two different, very, very different things. So don't worry.
About it. Yeah.
But don't worry about labels right now. Okay. You just that trauma, just the 10 years of sexual abuse is enough for me to say, however it's manifesting now, whether it's a personality disorder or a mood disorder or a complex PTSD, whatever it is, whatever we call it, these are the places to start. Okay. You got it?
Mm-hmm.
Okay. Start there.
But yeah, I just wanted to ask you because, I just want to make sure, because I feel like I feel like I've always wondered, I feel like I wasn't being treated, with my therapy, like it wasn't working.
Yeah.
And I don't know. I just want to see what the next step is besides CB, the cognitive.
Yeah.
And then also the EMDR, what's another way, or what kind of person or should I see and talk to besides a therapist and
you have to look for, the psychiatrist is for the meds if you need it, but the therapist are people that advertise themselves as specializing in sexual traumas, EMDR, and then the CBT person. Most therapists are pretty good at CBT these days, so it doesn't require necessarily any super special training. Let's just get you going again. Here's the deal: is that you've been getting care. And that's helped you be productive, and you're doing okay, and your symptoms are kind of under control. And sometimes that's the best you can do. But it sounds like you're really ready to go further and really get well. And that takes a lot of work and a lot of time, okay?
Yeah. Also I relate to the guy you were talking to previously about the electric thing, because I actually had to stop my Zoloft and my SSRI really abruptly because I couldn't afford it anymore. I became homeless. And then, I totally understand what you went through.
Kira, how are you going to be homeless and pay for 2 therapists a week?
I know it was hard, but I got back on my feet. I'm fine now, and that's why I'm seeking other therapy, music therapy. So I just wanted to get your advice.
All right, CBT, EMDR. It is now my privilege to welcome to the program the author of the Ultimate Manual with an emphasis on the man, Dr. Samadi's Guide to Men's Health and Wellness. Of course, Dr. Samadi is a urologist, and he specializes in all urological diseases, minimally invasive treatment for prostate cancer, including laparoscopic prostatectomy, laparoscopic robotic radical prostatectomy, and Dr. Samadi is currently Director of Men's Health at St. Francis Hospital, Roslyn Heights, New York. Roslyn Heights, yes?
That's correct.
Yeah, it's good to see you again.
Good
How
to
are
be
you?
with you. Thank you. I'm
Excellent.
doing great. Thank
Excellent.
you.
Excellent. And did I leave anything out?
No, I think that was a great introduction, and I appreciate you having me on your show, and also I appreciate endorsing this book. I know you read the whole
I
bunch
read
of
the
it,
whole thing, and it's easy because it was good. It's one thing if somebody asked me to endorse something, it's not good. Yours is, if I were writing the book, I'd put all that in there. And I thought it was very approachable and complete. And well, talk about it for a second. Talk about what people will find in the book.
Well, what's interesting is I've been practicing as a urologist for about 20 years. And what I notice is the difference between the way we think as men in the field of healthcare, as patients, as doctors, versus women. And I think there's a big, big difference. When I think women not only make 70% of healthcare decisions, they're the ones who are responsible and gatekeepers of our health. They're the ones who send us to see the doctors. Otherwise, we're just not going to go. And the attitude of men is, if it's not broken, then why should I fix it? And as you know better than me, in a lot of these silent killers, blood pressures, diabetes, prostate cancer, and so many of them, they don't have any symptoms. And by the time it gets to us, it's already too late. And we're dealing with fixing the disease today as opposed to taking care of people's health. A regular consultation for me when I see the man in my office for prostate cancer or any urologic issue is literally like average 10, 15 minutes. They're there, they want to get their answers, they want to get out of there. Whereas when they come with their wives or girlfriends, same consultation, it's 45 minutes, an hour, question after questions, and it just tells you.
That's so true.
I'm sure it's the same experience for you.
It's the same experience. It's always the wife bringing them in or dragging them in, and so men, the way we think about it is look, I'll find out soon enough. If it really starts to kill me, then I'll go. Otherwise, I'm going to pretend it's not nothing. And Susan, you want to tell the story? Oh, she says on mic. I had the same exact experience because I had H1N1 back in 2009. Nearly killed me. It was a terrible disease. And again, I keep pointing out to people that we had a pandemic in 2009. You don't even know it happened. It killed hundreds of thousands of people, but okay. But at the end of it, she went, that was not a normal reaction. There's something wrong with you. I'm like, look, I see a cardiologist for my hypertension. I've got a pulmonologist if I get pneumonia. Don't worry about it. I check my own PSA every year. It's no big deal. She goes, no, you're getting a physical from a general internist. I go, okay. She makes the appointment. I go in. My PSA had gone from 1 to 4. And my internist looks at me and goes, that makes me uncomfortable. I need to see a urologist. I need you to see a urologist. And I just said, forget it's me. Forget it's me. I'm not a colleague. Just forget it's me. I'll come back in 6 months and repeat it. You know it's going to be still before. He goes, just go see the urologist. So I go see the urologist, and he goes, yeah, probably fine. Take some antibiotics and anti-inflammatory. It's probably prostatitis. We'll repeat it in 3 weeks. Repeat it, still 4. Yeah, repeat it, take more, because he too was in denial with me. He was like, we'll try it again with prostatitis. It's 4. And he goes, well, now you need a biopsy. And I'm like, see what happens when you're too aggressive, when you don't give me 6 months to go home and check it out and give it a little time. Biopsy, cancer. So there you go. To me, that was a great story, not only in how important the wife is in getting the man into treatment, but also good judgment on the part of multiple physicians. Good judgment.
But absolutely, that's a great story that you just mentioned. Yeah. And this cancer that you had, obviously, as I said, no symptoms, and God forbid, by the time this would become significant, it would be already too late. So credit to Susan, she saved your life.
She did.
And I think that and the good news is that you are cured. You're doing great, and the outcome is wonderful, and you can enjoy your life. And that's exactly the message. This is a great story for a book like this. We want people not to ignore things when it's way at early stage. Go back to their 20s and 30s, educate them about what they should be eating, what exercise, what tests they should get, as opposed to finding them. I have patients come to my office, they're 60, 65-year-old, and I said, what is your PSA, or have you seen a doctor before? And goes, first time I'm walking in. And it's just incredible.
Or they go, I don't have any problems that way. I have no problems that way. I'm fine. Yeah, which is the usual thing I get. But and I also want to address the other side of this too, which is because everyone used very, very keen judgment, I was diagnosed very early. And I know in our fields, both general medicine and urology, there's even a conflict between how early and how aggressive we should be screening and following up. And so I went on active surveillance for a couple of years, which is, you can always, if you have a low-grade tumor, it's a small amount, you have that option. So now we have that option as well. Now back then, active surveillance meant a biopsy every 6 months. And that was a lot of fun. And what happened was the grade never changed, but I had a central tumor whose volume grew. So that was weird, and enough to trigger a prostatectomy.
Well, that's a point. So we need to look at the genetic component. We need to go back and see if your father, grandfather, or someone else had the prostate cancer.
Father and uncle.
There you go. So that's a major risk factor. Number two, the speed and the way the PSA velocity. Your PSA went from 1 to 4, or let's say it would have gone to 3.5. A lot of medical doctors may say, you know what, still less than 4, don't worry about it. But your doctor was smart enough to really bring the red flag. And your urologist absolutely did the right thing. They didn't jump straight into biopsy. They wanted to treat everything else. And one of the questions about elevated PSA is prostatitis and BPH and everything else that they ruled out. But the reason why, again, I wrote this book, Drew, is because even when you look at COVID-19, it affected men a lot more than women. You saw those articles that came out as a result of, either the Y chromosome or testosterone. Men, we're just much sicker. We live 5 years less than women. At every age, we're sicker than women. And look at diabetes, high blood pressure, and obesity. And when this virus came, guess what? It goes straight after these guys, and it really affected them. And that's why I think we need to wake up. We need to not only listen to our wives, but we need to take this as a personal responsibility and just go for maintenance. Don't wait until the car is broken and say, okay, now it's time, I'm going to go fix the car. And that's already too late. So that's a big message from this. Plus the fact that it has a lot of things about nutrition, which is a non-traditional book for a lot of robotic doctors like myself. We don't talk about diet. We don't talk about nutrition, vitamins. So I try to basically put all the notes that you and I have discussed in the media for the last 10, 12 years in one book for the public out there.
So I have 3 things I want to say and question. One, I want to say thank you for bringing the Da Vinci robot stateside here, because I benefited from your having brought this over. Number 1.
It's my pleasure.
Number 2, where can we buy the book?
It's on Amazon and Barnes & Nobles. The name of the book is called The Ultimate Manual. It just came out literally yesterday, and it's doing quite well.
Great. And then finally, we've got a bunch of calls lined up now I want to get to. But before I do, I want you to please, in maybe an abbreviated story, tell us what happened to you with the cancel culture, people that maybe didn't see your last appearance here. I want people to feel bad for you. So, and for us doctors generally, for how politics has interfered in the practice of medicine. But I'll let you tell your story.
Well, I didn't know if you were going to ask that question, but I think what happened was, number one, on social media, I woke up one day about 3 weeks ago, and the whole entire Twitter account was completely gone. There was no access to it, no this about this. And I try, you know me for a long time from the media, I always try to keep it very balanced and put out good studies out there, do the right research and everything. Yep. So I never was out there saying this medication can cure you, or this is but it was a big surprise that the videos from social media, Instagram, Facebook, and the whole Twitter was shut down. Of course, we made a big stink about this. I talked about the censorship about doctors. And I think it's a very, very dangerous time in America when doctors cannot talk about the medicine part. So in any medical conference, we've had ground rounds. We've been in academic for 20 years. I can talk about, for example, watchful waiting. You can say, no way, we've got to do surgery. And we're not going to censor each other. This is a medical discussion. If somebody thinks, for example, hydroxychloroquine could work, and I may think that it may or may not work, this is a very healthy discussion. And censorship in America should stop. And people, especially doctors, should be able to read the articles, interpret, dissect what they think, and just give it to the public.
See, this is what people don't understand. They're like, "What? You guys are always changing your story." Yes, that's how science works, particularly biological sciences. We spend our years in medical school and residency and the rest of our career reading large volumes of literature so we can understand the science that's going on in the moment across our field, so we can contextualize any new literature that comes out. We read that, we're trained at assessing it, we assess it, we have our own opinion about it. We are trained to have our own opinion and then argue it out with our peers and figure out where the truth is. So that now has suddenly become the realm of governors and politicians, which it is anathema. It is disturbing like you can't imagine. And then the idea that we can't have a public discourse about it, it's too much.
It's a sad time. It's very difficult. And I know a lot of doctors, even from academic institutions and private hospitals, are under pressure that they cannot openly discuss a lot of things. But the whole idea behind this was to really save lives, give a lot of good information, a surprise pandemic that came out of nowhere, and really to help people out there as the job that you do every day. And I'm sure a lot of people really appreciate what you're doing.
The anybody but Trump guy from, I guess he's on Periscope, please show me where I've suggested that we should not have randomized control studies on hydroxychloroquine. What I keep saying is it's designed for early use. We need a zinc, azithromycin, hydroxychloroquine randomized control trial for early COVID and nothing more. We can't say anything else. It's not a prophylactic. It's not for late disease. We know that for sure. It was meant for early and viral reproduction, and for some reason those randomized control studies have not been done. I don't understand why not. In the meantime, I can't recommend it because we don't have those studies. Absolutely. But there are doctors that have anecdotal studies where they show some benefit. So it may, while we're waiting for those randomized control studies to be done, it may have some benefit. In the meantime, anybody but Trump, shall we have people die? Shall we just let people go?
Well, I think the way look, this is where I think we kind of, the narrative went to the mainstream media, and the governors and politicians got ahead of even doctors and physicians.
Yep.
I think that, what you're saying is absolutely correct. In a normal way of life, we want to have those randomized, prospective, evidence-based medicine kind of a thing. But when they come and they tell you that by next week, you're going to have 2 million people dead from this. We have no idea who's going to go after. We have no idea how contagious this is. By the way, we don't have much of ventilators. We have no PPEs. Yeah. Good luck to you. Yeah. When it comes to situations like this, and the lockdown was the only answer that they could come up with, there were a lot of people that wanted to look into different kind of medications. And if there's something out there that the risk of it is low and can save lives, that's how that went. But I think that discussion has put to rest already.
Yeah, and by the way, I have prescribed that there's 1,000 pills out there with my name on it. In fact, I was doing I was doing my continuing medical education on rheumatology, and they were advocating that not only should Plaquenil be used liberally in lupus, ankylosing spondylitis, rheumatoid arthritis, but it should be left on during pregnancy, because it's so safe. I don't know any medication that I would feel comfortable leaving on during pregnancy. Plaquenil should do.
That's true.
As an absolute.
Millions and millions of prescription has been written, and there hasn't been any tragedy or any major issues. But unfortunately, this is a political year, and that plays a big role in some of the decisions that's been made.
So we have some questions. We have some interesting urological questions. You ready for them?
Sure.
All right, Jason. Have at it, Jason.
Hi. Yes, I have heard that if a man is circumcised at birth, over the course of his lifetime, his penis head will eventually become desensitized. And when the man gets in his 50s and 60s, that he's 4 times more likely to need erectile dysfunction drugs. And I was wondering if that's true or not.
All right.
Well, that's a very good question. I like that question. But, there has been a lot of literature about this written, not so much about erectile dysfunction, because the erectile dysfunction has to do with the blood flow through the cavernous arteries, and it's a different mechanism. But there has been articles written about the fact that sometimes circumcision can desensitize some of those nerves, or even oversensitize some of those nerve endings, and can lead to premature ejaculations, which we have a lot of different treatments and medications, and it's all in that book. I have a chapter on that. But certainly, I think one of the main reasons why people get to their 50s and 60s with erectile dysfunction has to do with some of the medications that we're taking. Some of the worst ones are blood pressure medications. There's also could be some pre-diabetic disease that you may not be aware of that could cause like vascular issues. Those are the main ones. And I think seeing a urologist and getting a Doppler study and finding out about the flow can put that discussion to rest. Fortunately, we have a lot of great medications today that we can treat this.
I, by the way, if a man is above the age of 40, particularly a smoker, has erectile dysfunction, I put him on a treadmill. It's often a presenting sign of heart disease.
That's a great point, because when people are going to have an early massive heart attack, the arteries, the penile arteries, are much smaller, and that's the first place. That's a very good point you're bringing up. That can cause erectile dysfunction. So a man in his 40, when he comes in with ED, it could be either psychological issues, which you have to rule out, could be anxiety performance, new girlfriend cannot perform, or there could be real physiologic issues, as you mentioned. And the first place to go is to go see a cardiologist and get a complete workup of his heart. That's a great point.
And I'm going to make another point, too, of an interpersonal point. Having done a talk show for many years where these problems came up. When you mention men having erectile dysfunction from anxiety, when that happens, first of all, the woman feels diminished and starts sort of coming at the guy, you're not attracted to me, there's something about me, when in fact the source of the anxiety is usually they're too attracted, they're too into the case, they're too into this girl, and that makes them sort of overwhelmed, and that's when they dysfunction.
And that's exactly where she needs to make sure that he is comfortable and he can perform and she can kind of carry him along the path. Sometimes I see a lot of young 25, 30-year-olds. I don't know why they're all in hedge fund business or stress of this stock market. They're all in 27, 30s, 25-year-olds that come in with erectile dysfunction. And what works really well is a very low dose of Cialis, 5 milligram, that can get them through. It's like a bridge medication.
Right.
It's not addictive. Correct. And it takes them over this anxiety.
Over the hump, as it were. Mike, go ahead there.
Yes, doctors, I have an interesting dilemma or an interesting problem that I'd like to hear more about. And that I'm one of those cases of high PSA. I've had three magnetic MRIs, and I've had two biopsies, all showing conclusively negative, no signs of any cancer. But yet I have been running a very high PSA for a couple years now, and the doctor has. I think you said it was BPH. Is that the condition?
Correct.
Where an enlarged prostate, for the enlarged prostate.
Yeah.
The good news is I'm told that I don't have cancer, but the bad news is that there's still a 30% chance that I might develop it over my lifetime. So I'd like to have a little more information about the BPH issue, because my PSAs freak people out when I tell people my PSA number.
I'm surprised by that.
Your PSA?
My baseline is 10.
Wow. And can you empty your bladder?
Yep.
All right. Dr. Samadi, I'm surprised he came up with that 30% number. I'm not aware of that.
Well, what they're basically
the
saying
analysis
is,
that the urology doctor did was that there's some based on the size of the prostate and other factors. There's a factor of you still might develop cancer in your lifetime.
Right. And I know it can hide in the BPH. Do you have a family history of prostate cancer?
Nope.
Okay. Now let's let the urologist answer. Go ahead.
Yeah, so I think that, depending on how big the size of your prostate is, and sometimes we get to normal size prostate should be around 30, 40 grams. When you get to your 60s, you should be around 50 grams. But once you hit like big size prostates, and I have a lot of patients that have prostates the size of 90, 100, 130 gram prostates, doing a biopsy on such a huge piece of real estate, a big prostate, is always, it's a hit and miss, even though the MRI is a great tool to use. And that's where that 30% comes in. They basically put in your age, they put the PSA, and there are nomograms that can predict that you may have a chance of developing prostate cancer.
That sounds, hang on, I'll interrupt you. That sounds a little, is that widely accepted?
It's a little too high. It's a little too high, but they're probably trying to scare him to make sure that he doesn't disappear and he would follow up in the future.
Got it.
The fact is that you've had 3 biopsies. You have to assume that on the average, they have taken about 12 cores. So they have gone after this prostate somewhere between 30 to 40 times. And the likelihood of finding cancer in your prostate is very, very low. Not that it's impossible, but I would basically follow your PSA, look at a trend every 6 months to a year. I think you should just have a rectal exam, and most likely you'll be fine. If you start having problems with frequency, urgency, getting up in the middle of the night, sometimes you may have non-clinical significant prostatitis that can lead to this kind of PSA, or you may be retaining, as Dr. Drew started to ask you, you may be retaining some urine that can lead to some of these issues that you have. And, it's very easy to follow you and fix this problem.
So because I like taking care of very, very sick people, I end up with what now is a lot of elderly in my population. And I cannot tell you what a problem that becomes in the very elderly with urinary retention. I mean, it really becomes a challenging thing so often. And I don't know, is there a way to prepare people for that? I've never found any way to sort of anticipate it.
It's right here. It's in this book. And so the reason for this is, Drew, when we went through medical school or residency, we didn't see people go to their 80s and 90s, and people used to die, from heart disease, heart attack early on. So this wasn't a problem. Now we see mental illness and things like you mentioned, retention becomes a big problem because, we see a lot of people in their 80s and 90s, and they live long, mainly because of all the cardiac issues is being handled by you guys very effectively. So I think that if you're in your 40s, start seeing a urologist, get a baseline, your PSA. If there are no genetic components, there's no risk factor, you can go to your 50s and follow up once a year to make sure that you're fine. There are some men out there who have premature, really enlarged prostate. They may have a big middle lobe or median lobe. So it's good to study them and fix this early on. There are a lot of medical treatments. Today we have a lot of minimum invasive procedure that has come, Urolift, shaving of the prostate, laser, so many other things that we can do. So when they get to their 70s, 80s, they don't end up with those suprapubic tubes and catheters, and it's a really big drag, very difficult to manage them at that point.
You can't really do those procedures when they're that old, and what you end up with is retention, recurrent urine infections, hydronephrosis, renal insufficiency.
Correct.
And it's a cult, and people in their 85s come in sick all the time, and when somebody has obstructive uropathy, every time they come in sick, you have to go, is it kidney failure? Did he not know he wasn't emptying his bladder? And
so
really
part of it is because that's so true, and part of it is because when men get older and they start getting up in the middle of the night and they don't empty their bladder well, they think that's a normal process of life. Well, I'm getting older, so that's why I need to get up a couple of times. But that's when we want to intervene and prevent the prostate to affect the bladder. One of the things that you're talking about, the fact that things are backing up to their kidneys and hydronephrosis and affecting their kidneys, is once the bladder loses the effect and that elasticity, that's an irreversible phenomenon. And that's why intervening at the beginning and seeing the doctor can save your bladder for when you get older. That's an excellent point you brought up.
We're going to take a break in a minute, but I have 2 questions for you before we do. Number one, there's a lot of chatter on my feed here to clarify your hydroxychloroquine position these days. Where are you with that?
I think that when it's diagnosed early on and ignoring the symptoms are the worst thing. When the doctor says, wait another 5 days and go to the ER if you have a problem. When it's diagnosed early, when it's given at a very early stage, along with the zinc and antibiotics that you mentioned, it could be very effective. I think this medication is absolutely useless when it's given at the late stage. By the time all the inflammatory cytokine storms and the inflammatory process has kicked in, it's already a waste of time. So and it has a record of working on those early stage. We all have had friends, families, and tons of people that have taken it and have done very well.
Yeah, I don't think the public knows how often it's prescribed. I prescribed it many times to good effect, and certainly it's harmless. It's just harmless to do so. And I don't know. Though we don't have the double-blind placebo-controlled trials yet to know if we're really doing anything. We're certainly not hurting anything. And of the many times I prescribed it, only one case in my cohort went into cytokine storm, and he did it like in day one. He was a very rapid into cytokine storm.
Correct. And it breaks the cycle. So the issue is some anchors that you are aware of, they basically came publicly and they looked straight into the camera and they said, if you take this medication, this can kill you. And then following that immediately, a lot of other anchors ran and they talked about cardiac issues and arrhythmia and they brought a couple of cardiologists.
Hydroxychloroquine is available over the counter in most country. I have prescribed it 1,000 times for malaria. It does cause mental status changes. I would not take chloroquine. I don't think it's a good idea. Hydroxychloroquine, there's at least 1,000 pills out there with my name on it that I've used for lupus and rheumatoid arthritis and other things over the years. And we would always say, hey, so go see the ophthalmologist every year because there's this retinal thing that happens. Never seen a retinal side effect and never seen a single side effect from hydroxychloroquine. And as I said, it's supposed to be maintained during pregnancy. It's considered so safe that you're asked not to take it off during pregnancy if you have a lupus patient, which is, I don't know any other medication that from the MKSAP, they tell you keep it on during pregnancy. I just literally don't know.
How many of your patients, out of all these thousands of prescriptions that you have written, how many of your patients actually died? How many of them had massive heart attacks? And how many of them had major cardiac arrhythmia that had to be admitted to the hospital?
Zero. We just say any side effect.
That's the answer.
Zero. And the other thing is, now I'm going to ask I've been wanting to ask a urologist this question for a while, and you may not have an answer, and it may be unfair, and I need to kind of set it up a little bit. Is it not true that females have a periurethral gland that, if you look at on the path specimen, is essentially identical to prostate tissue? Is that true?
I've never heard of that, and I know that there are periurethral glands. Men have it and women have it.
Yeah.
One of the things that we see, I'm not aware that it looks like prostate, but one of the things that we see, because the urethra in women is quite short, it's only about like 4 centimeters, and there's a lot of bacteria, vaginal and rectal bacteria that can get to that. A lot of times we see some constriction, almost like pseudospasm in the urethra as a result of these chronic infections that they've been getting. It almost behaves like prostate. It's not prostate, but basically it becomes narrow. The urethra becomes narrow, and the symptoms that develops in women is very similar. And what you do is very simple. There are urethral dilators that we can basically use. It's absolutely no pain. And you dilate the urethra every 6 months, once a year, and they do amazingly well. And all the symptoms, believe it or not, goes away, and they're very happy. And it reduces the risk of getting future urinary tract infections.
So my question was going to be, I started thinking about all the female to male transgenders, gender individuals out there, and whether the testosterone was doing anything to that periurethral gland, or developing prostate tissue, or putting people at risk for prostate cancer. Has anything like that ever been discovered?
No, I don't think so. You're talking about female to male, right?
Yeah,
Not male
female
to
male
female.
to male.
No,
obviously male to
so.
female has its own thing. At least you don't take. Well, sometimes do they take the prostate out when they do the surgery?
No.
Yeah.
No, the prostate stays there, and you have to monitor them, and it's tricky. But because they've been taking a lot of estrogens, there's a lot of shrinkage of the gland. So, but they still need to be maintained.
Does it reduce the risk of prostate cancer?
It does.
Yeah,
it does. But I've had, years ago in residency, we have taken a prostate out of a transsexual patient, which is an interesting case.
I would imagine that would create all kinds of potential for urinary problems, and you wouldn't necessarily
Correct.
want that. And of course, now that you have the robotic thing, you don't have to worry about the sexual dysfunction so much.
Well, the robotics really revolutionized the field when it comes to sexual function and urinary control in the hands of really experienced people, doctors who've done thousands of these. This was a major, major change from cutting people open to even laparoscopic cases that we did in Europe. This was a big deal, and I've been doing this obviously for the last 20 years, and it becomes part of our life.
I'm going to take a break. Before I do, Nicole, I see that you're talking about your systemic lupus erythematosus out there with multiple organ effects. My honey, that is a rough illness, and hang in there, my dear. Make sure you have a great urologist. There was something else I wanted to say. Oh, the Prostate Cancer Foundation. That's another place you can go. I'm very involved with them. Do you work with them, Dr. Samadi, PCF?
Yeah, sure. Directly and indirectly, we've done a lot of fundraising for them, and they do an amazing job. And it's all great cause. Of course, September, we're at the month which is known for prostate cancer, and you still see 30,000 men die from this disease. It's absolutely, through screening, knowing your PSA, seeing a urologist, this can be prevented and we can save many lives. And there's a lot of information. If people want to know, to go to prostatecancer911.com. There are tons of information there. And if anybody is diagnosed with prostate cancer, or they have had prostate cancer and they have questions, they can go and email me, and I'll be happy to help them and take care of them.
Right. All right, we'll take a little break. Is there a website or something you'd like to send people to, Dr. Samadi, or a Twitter handle? Or
prostatecancer911.com. Prostatecancer911.com is where they can send me their information or any questions that they may have.
All right, we'll take a little break. Back with Dr. Samadi after the break. With so much focus on keeping ourselves and our loved ones safe and healthy, it's easy to forget that most of us are going to experience things like allergies, colds, possibly even the flu. So, reminding you, proper hydration is crucial for all of these things. Remember, even slight dehydration can make you feel like you're getting sick, and none of us need that anxiety right now, that's for sure. That's where Hydrolyte comes in. Longtime fans will remember my obsession with Hydrolyte, which is simply the best oral rehydration product I've tried. I'm even more excited to introduce their brand new single-serve powder sticks. Simply pour one powder stick into a glass of water. They recommend 7 ounces. The powder dissolves almost instantly, creating the perfect balance of sodium, glucose, and water. Delivers up to 4 times the electrolytes of your typical sports drink. The other great news about Hydrolyte's new powder sticks, they're 100% all natural, no artificial flavors, colors, or sweeteners. They're available in flavors like orange and lemonade, and they taste great. Hydration is crucial, and Hydrolyte is fastest and easiest way to stay ahead of it. Get your supply of Hydrolyte powder sticks now at hydrolyte.com/DRDREW. Again, that's HYDRALYTE.com/DRDREW, and then use that code Dr. Drew 25 at checkout. The World Health Organization estimates that each year approximately 1 million people take their own life. That's one death every 40 seconds. Experts predicted numbers would peak in 2020, but no one could have imagined the devastation brought on by COVID-19. During the coronavirus pandemic, you may experience anxiety, sadness, and loneliness. Existing mental health conditions, including severe anxiety and major depression, may worsen. If you're feeling hopeless, contemplating self-harm, or you're concerned about someone else, I'm here to tell you there is hope. A Mission for Michael is dedicated to helping clients achieve complete inner and outer transformation. Mission for Michael is the premier resource for intensive mental health treatment in Southern California. With an astonishing 2-to-1 client-to-staff ratio, each client in their facility receives individual care 24 hours a day, overseen by a team of all doctorate or master's level clinicians. With a focus on evidence-based treatment, along with personalized and compassionate care, they offer mental health treatment that can change lives. If you're suffering from mental illness or you're concerned about a loved one, go to amfmtreatment.com. Again, that's a mission for Michael, amfmtreatment.com, or call 866-581-4401. Again, that is 866-581-4401. All right, we are back with Dr. Samadi. Again, the book is The Ultimate Manual. Let's put that up there. I want you all to, if you have any, there you are, The Ultimate Manual, Guide to Men's Health and Wellness. And again, it's really a good book, and it's very easy to read and very easy to understand, and I think people would benefit from it. If you're out there, you know, any of these comedies, as they always say, you don't want a female genital tract before the age of 50, and you don't want a man's after 50. And that's just kind of the way it goes. Some people say 40, depending on. We, much the way women need to attend to that tract, men have to attend after a certain age, and this will explain all that to you.
Well said.
Again, the website is Prostate 911. Is that it?
It's prostatecancer911.com. Tons of information on prostate cancer.
Dr. Samadi, I have abused your time. I'm going to let you go. I appreciate you being here again with us, and congratulations on the book. And again, thank you for
so much.
bringing the robot so I could be a beneficiary as a patient of that instrument. And we'll talk again, no doubt.
I'm glad you're cancer-free, and I'm glad you're doing well, and I really appreciate you bringing me on your program.
You got it. Thank you, sir. That is
Take care, my
Samadi.
friend.
We'll talk to you soon. And I see you guys all in the chat thread here. Yes, Sly, do call Sly. Why not? I would certainly recommend you do call. And I do have some calls to get to. Let me just quickly look at the thread here. You're all saying thank you, Dr. Samadi, and I appreciate that, and so does he. Let me quickly go through here. All right, I'm going to get to another special guest in just a second here. This is one of the stars of. Oop! I still see Dr. Samadi. Is he still up there? Is that he's just watching us? Did Sly call in? I wanted to let him get up here. No, he did not. All right. My next guest is someone who is starring in Andy Dick's new nefarious, what shall we say, remake of the Tiger King. Are you there? Special guest? Simona? Wait, Susan's got to make the adjust. Yeah. There you are. Simona. I hear you breathing. Simona Mangiante, is that you?
Yeah.
There you are.
Hi, how are you?
We are great.
Hi.
Tell us about the new movie.
Thank you. Today is Tiger Dick, and we're very happy to share this with you. I'm here far away in Italy with George, my husband, visiting my family, and we thought that this was most the timing for us to join you after dark. But we're synchronized with the jet lag, so just talking about the movie coming out. It's a series trailer coming out, which is extremely funny.
So, Simona, what's interesting, your accent has gotten heavier since you spent the last couple of weeks in Italy, which is hysterical, which is really funny.
But 2 months.
2 months.
Exactly.
It's gotten to you. But that's okay. It's very charming. And Simona is George Papadopoulos' wife. They've both been very active on Twitter the last few weeks. And I'm trying to read through some of George's tweets to understand what's coming or what's happening. Any spoilers for us? And then we'll talk about Tiger Dick. Is that what it's called? Tiger Dick? Tiger Dick. Tiger Dick. Okay.
Tiger Dick, and the Dick, Tiger Dick. Yes, exactly.
So like Andy Dick.
Title.
Andy Dick is what's the guy's name from Tiger King? Help me.
It's Joe Exotic.
What's his name?
Joe Exotic.
Joe Exotic. And can you imagine now we've got Carol Baskin's going to be on Dancing with the Stars. It's a perfect time for this movie to come out.
Oh, really? Dancing with the Stars? Amazing. I can't wait to come and see it.
So what it was, I've seen the trailer. I've seen the trailer for this. It really, really does look very, very funny. Where can we find it?
I'm posting it on
Oh, Susan's putting it on the stream. Well, tell us anyway, for people that aren't.
There are sneak peeks. There are sneak peeks on Facebook. You can start to watch it online. It's live. And I'm supposed to have an accent in this trailer, so if you say it got stronger since I'm in Italy, that's going to help me moving forward the next episode.
so it's Facebook. I'm looking at it right now online. It's facebook.com/TigerDickTV. So it's TigerDick TV.
Yeah, exactly.
Tiger Dick TV. All right, Simona.
There's the page. That's Tiger TV. Tiger Dick TV.
Congratulations. I just wanted to give a chance to say hello. And when are you guys coming back stateside?
Thank you so much. We are coming back shortly in probably 3 days. We're booking our tickets right now, and we can wait to go back and probably come in studio with you.
Great. We'll do that. And you guys coming back to Southern California?
Yeah, Los Angeles.
All right, perfect. All right, Simona, say hi to George for me.
Yes, it says I too.
Okay, bye-bye. In fact, you have... I'm putting
We
you back.
say we want to...
Oops, sorry. I can't, this system has a little delay to it. So, say, George, hi, man. I know you're there. Thank you, and we'll see you when you get back stateside here. Okay, I've got a whole bunch of questions here. We've got to wrap things up in about 15 minutes. I'm a little nervous about getting some... Kelly Gallagher, no, it was prostate cancer I had. Prostate cancer, very different kind of a thing. Very different. The colon cancer is a much more serious deal. Prostate cancer is the most common cancer after breast cancer, and a lot of men get it, and it's highly, highly treatable these days. Okay, so I'm going to try to get some questions. I'm a little nervous about getting to some of these because there are a lot of very difficult questions. Hold on a second. Oh, my goodness. It's hard for me to tell because each of these are in very, very different directions. Let me try to get to Leopold here. Go ahead. Hi, Leopold. What's going on?
Hey, Dr. Drew. It's wonderful finally getting to talk to you.
You as well.
Other than email, but it's wonderful, and you've done some amazing service through the years. But my problem is kind of the opposite of folks who, premature ejaculation. My problem is that I have a hard time ejaculating.
Are you on any medication?
Well, the medications that I'm on is for the high lipid cholesterol.
Mm-hmm.
And I do take ED medication, and I'm pre-diabetic. But this problem I've had for about 30 years.
What about that 30 years? What'd you say?
Well, I've had this problem for 30 years of not being able to ejaculate while having sex.
So that's called delayed ejaculation. It is... The way I think about that, if there's not something medical going on, which the most common thing being medication, obviously diabetes, things like that can figure into it, but this is something you've had long term, so it's not something new related to your current medical treatment or medical problems. And some guy, every male kind of has a clock. He has his own sort of rhythm. Some it's a stopwatch, and others it's a calendar. And the key is... with these situations is not so much to, particularly with delay, there's not a lot that can be done to change that biology. So it's about working it out with your partner to figure out together how to best work with this. It's something you got to kind of work with. Have you guys been able to satisfactorily do that?
Well, my current fiance is very understanding. And she's actually sitting right next to me as I'm having this conversation, so she's very open to me talking to you. I actually lost. I'm sorry.
I want her to understand. This is the main thing that you have to do to coach up your partner. It has nothing to do with her. It is not about her. This is not as though you're not attracted or there's something about her or something she's doing. There's none of that. It's more about kind of figuring out what works for both of you and putting that together.
And she's been wonderful about this and has not given me any issues. I actually lost a wife in part due to this. My ex-wife wanted me to go to therapy, and I had all kinds. She was very upset that I couldn't finish with her and took it personally. And like I said, it was a contributing factor to divorce.
Wow, I'm sorry you had to go through that, Leopold. I really am. But I'm glad you have a new partner, and I'm glad she gets it, that it's just a biology. It's just a biology you're dealing with, and that's that. Nothing to do with her. And I'm sure you could not be more excited to be with her than you actually are. So that's how I know how men operate. Thanks, Leopold. I've got to keep moving here because I've got limited time and a bunch of calls here. We're going to go to the other end. Well, let's go to something. We're going to switch topics here. Oh boy. John, go ahead there. You waited a long time. John.
Thanks, Dr. Drew. First time, long time. Thanks for my call. Taking my call. I, especially Dr. Samadi, I felt compelled to call because I feel compelled to talk about how physicians could really, particularly surgeons, could really turn off new opioid addicts, the faucet for new opioid addicts, if they implemented what's called enhanced recovery after surgery protocols.
Okay, talk about it.
Are you familiar with ERAS protocols?
No, go ahead.
Well, basically what it means is that it started about 15 years ago in Europe, and they treat the pain of the medication before the operation. Mm-hmm. So you do things like give Celebrex and Lyrica and Tylenol before the operation. Mm-hmm. So that when you come out of it, you don't need the sledgehammer of morphine or opioids.
Right.
And these are generic, they're cheap, it's just proactive. And they're across the board has shown statistical evidence that you can basically eliminate opioids entirely and certainly eliminate the need or, the propensity for addiction.
I know that
physicians aren't talking about it.
Yeah. I'm totally supportive of that. I have no problem with all. In fact, there's an emergency room in New Jersey that will not prescribe opiates and only uses modalities like you're describing here for all pain, which is very interesting. And so I'm very supportive of all that. But here's the deal. Opiate addiction does not occur in the 3 days following a surgery. It just does not. Because a problem when they leave the hospital and they're given 120 pills, that's when people get into trouble.
Yeah.
And then it's refilled automatically and all this stuff. The other thing is, even if you're an opiate addict, if you are an opiate addict, of course I'd prefer that this enhanced surgery, enhanced recovery be utilized. But even those patients, there's a way in somebody's hands like myself, there's a way you can use opiates and get them through that without triggering their addiction, even when they are severe addicts. So there's things that can be done, in addition. But I completely agree that all these other modalities got to be considered, and the massive enthusiasm for opiates, I hope, has been somewhat diminished by the extreme consequences that this country, many countries, have suffered. It's just ridiculous. All right, we're going to go to the other end of the spectrum here. This is Wiley. Wiley, go ahead.
Hey, Dr. Drew. Big fan. Little starstruck. Very nervous.
Hang in there.
Can you hear me?
Yeah, I got you.
Okay. Basically, my question is about premature ejaculation. I'm 27. I've, never actually done the deed, but it's less than 4 strokes, and can't really keep it going. But I was wondering if you have any advice, because it's hard to get your confidence up to go out there and, get yourself out there when you don't feel like you can,
So too quick, right?
Too quick, and the refractory period is too long. Like, I was wondering if there's anything I could do about that, maybe. So I could,
that's
again.
That's back to biology. I mean, this is going to sound weird, but you can kind of practice. You know what I mean? That's one thing you can do. See if you can overcome that. Number one. Number two. There are numbing creams. You can put a numbing cream on and a condom, and that will slow things down a little bit. Have you also thought about maybe taking a bullet or two out of the chamber before you head into action?
Yeah, the thing is, I take Zoloft, and that kind of helps a little bit. I've noticed when I'm on the Zoloft, I last a bit longer, but it's still, it's not, I don't feel it's adequate, so to speak, but it's just, it's very, it drives my anxiety up, because I just feel like it's hard to put yourself out there.
I hear you. I hear what you're saying. It's not that I don't hear you, and I'm fascinated that your worth is deeply affected by it. I think you used the word adequacy. And that's a common thing.
Well, yeah, because also I'm 27 here, and I've never actually, had any sex. It's just because it's something that weighs on me.
Right. So what I'm going to tell you is this is not just about the premature ejaculation. There's something else going on, that this is just another straw on the camel's back that puts you over the top a little bit, because a lot of women are actually flattered by the quick draw. And so it's not necessarily the case that it's something you have to feel extremely uncomfortable about. Number two, again, the fact that you generally feel inadequate, and this is just adding to that, to me, it's a perfect reason to go talk to somebody. I mean, really, you've got to kind of explore this a little further and see what's up, where's the anxiety coming from, what's with the adequacy issues. How can you, when you have that, it's almost like, fighters have somebody in the corner for them. You need somebody like that you can go talk to on a regular basis. And then when you go out in the world to date or whatever it might be, you have this person you can go back to sort of be, I don't necessarily want it to be a coach. I really want it to be a therapist, but somebody who's there to support you makes a huge, huge, huge difference. And so I am recommending in the strongest terms that you really, get a therapist going and really kind of delve deep into these issues and use that person as a resource. Okay, I have to begin wrapping things up, you guys. It's been a pleasure to talk to you. Thank you for all your calls. As always, I leave people on hold, and I feel guilty about that, and I'm sorry, but we literally run out of time. We appreciate those of you giving us the super chats. I'm looking at the thread to see if there's anything else I need to respond to before we get in here. In LA County right now, I want to look at the data here. We are at 439 cases today, which is ridiculously low. 194 in Orange County. I don't think they've modified that. I was looking at the graphs on California and the United States, and it just keeps getting better and better. Now, that doesn't mean it couldn't turn around and get worse again, but the data really, we're doing a good job here, and we should be applauded for that. The fact that my county is canceling Halloween is a travesty, and God only knows what else, other emotional damage that's going to do to our children. But again, they don't trust us to go out and wear masks and to circulate, so they canceled it in Los Angeles County. That is a disaster. That is really, it's time for civil disobedience, everybody. Time for civil disobedience. Go have Halloween. That's what I'm recommending. Okay, everybody, we're going to wrap this up. We appreciate it very much. We're in here tomorrow with Dr. Yohendra. Dr. Yo in here tomorrow. We're going to go deep again. Not so much on leronlimab, but we'll get some of that in. We are going to talk to two people that recovered from COVID who were critically ill, one of whom received leronlimab just at the time she was receiving last rites, and it really turned her around completely, and she is now perfectly well. So we'll talk about long haulers, we'll talk about new treatments, new biology, the vaccine therapies. You know how deep in Dr. Yo goes, we're going to go with him. And we will see you tomorrow at, is it Susan, 3 o'clock? Is that correct?
Yes.
3 o'clock tomorrow. We'll see you then. According to SAMHSA's National Survey on Drug Use and Health, approximately 20.3 million people above the age 12 suffer from substance use disorder. Incredible. The disease of addiction takes an average of 130 Americans every day. Sadly, the opioid crisis, which many consider the worst pandemic of our time, has been even further perpetuated by the spread of COVID-19. Since the start of the coronavirus outbreak, drug overdoses have increased by 18%. Factors like economic stress and social isolation have led to increased depression and unnecessary deaths. A Better Life Recovery is a premier addiction treatment center in Southern California, offering one of the most highly regarded and comprehensive addiction treatment programs in the United States. Dedicated to helping its clients achieve complete inner and outer transformation, they offer a 45 to 90-day program custom tailored to meet the needs of each individual client. Long-term is the way to go. Many of A Better Life's clients elect to stay up to 9 months to receive additional support. A Better Life Recovery will do whatever it takes for as long as it takes to ensure the success of every client. Are you ready for a better life? Go to abetterliferecovery.com or call 866-581-4401 now.